Anterior capsular phimosis or contraction syndrome. Now we can appreciate in this case, this is a case which was operated with phacomyosification about 2.5 years back, and right now we can see that the pupillary mydriasis, even in spite of mydriatic, is not very good, and behind that we can see a collar like contraction of the anterior capsular excess margin, which has brought down the capsular opening to something like 2 to 3 millimeters. And we will be fortunate here because I had this surgery also with me, and here is this is a compilation of this patient's picture at 2.5 years after the surgery, and the surgery which was done at that time in the past. Now we can see this patient has a prominent arcus senilis, and the pupil at this moment is fairly nicely dilated, and there's a nuclear sclerosis cataract for which the patient is planned for cataract surgery. However, because the pupil was progressively getting smaller, so the capsular excess was attempted, which was not very large but still not very small also. I would make an assessment of something like 5 millimeters or so. So a hydrodissection is being done, and rest of the surgery we can appreciate that the pupil progressively grows smaller and smaller, and this patient coexistingly had a comorbidity of having diabetes mellitus and being treated for hypertension, which were controlled at the time of the surgery. So I can appreciate that these also may be a contributing factor for this particular situation which the patient had presented to us at the time lag of 2.5 years. So rest of the surgery there is not much to comment upon. It's a grade 2 to 3 nucleus, and just because the pupil is not very well dilated, rather it gets progressively smaller during the surgery. That makes the surgery little tricky, but still it was not very difficult and manageable. So going ahead with nuclear dismantling and also emulsifying the pieces as they come to the handpiece. Once a major portion of the nucleus has been consumed, we can appreciate that the pupil at this moment is slightly larger just because the aspiration has been turned off, and because of hydrostatic pressure the pupil has dilated a little bit, removing the cortical matter. Small pupils have a problem that the subincisional and the cortical matter, which is very close to the pupillary border, may cause engagement of iris as well, so one has to be very careful. But overall this surgery was not eventful, and because there's some amount of cortex which is hidden behind and has to be removed, so I have used a Klugen's hook so as to retract the iris back so that none of the cortical matter is left behind for a surprise later on. So we can see this extensive sheet of cortical matter which needs removal, and this also needs management of the iris by pulling it to one side so that the underlying cortex is well exposed. So we can appreciate the cortex has been removed in toto, and now proceeding for the implantation of intraocular lens. And looking at the iris and the pupil, we can appreciate the iris is atonic, and this was a lady, so there was not a possibility of floppy iris syndrome, because these patients though may receive alpha blockers for other diseases, but this patient didn't receive any alpha blockers also. So this was basically an iris which was, because of aging, progressively got atonic, and somehow the reasons which are not very obvious to me, the per-op performance of this iris and pupil was not optimum. However, the surgery was finished without any hiccups. Now, once the surgery was finished, patient get good vision out of this, and immediate post-op photographs are not available. However, this photograph taken 2.5 years after the surgery clearly shows that the anterior capsular margin has contracted down to so much like 2 to 3 millimeters of size, when initially when it was done it was clearly more than 5 millimeters in size. So this is natural history or progression of a patient who had capsular excess phimosis or capsular excess contraction syndrome as it happens and progresses with time. Thank you.